Good morning. I'm so thrilled to be able to welcome you this morning and to kickstart our conference. I'm Ebru Kaya. I'm the current president of the Canadian Society of Palliative Care Physicians, and my colleague beside me, Dr. Leonie Herx, is a past president, and together we're going to be the moderators for our day for these sessions today. Just before I introduce our first amazing speaker, I just want to let you know that we're so grateful that we've been able to partner with this conference yet again. Our society is the National Association for Palliative Care Physicians in Canada, and we've been partnering and able to put on the Masterclass for many years now. So very grateful that we're able to hold it in person yet again with some of our audience virtually as well. So we've got a fantastic hybrid session. And I just have some housekeeping notes that I'm going to go through as well. So just bear with me, but I won't be too long. Okay, so the CME sign-in desk is located in the main lobby. Oops, nope, I didn't want to do that. And participants must sign in, oh, for God's sake, must sign in daily to obtain credit as well as complete online evaluation forms on the app for each session that they attend, and certificates of attendance will be emailed after the Congress. Sorry, I have to read out every single thing, so I don't want to miss anything. And just to let you know that our Scientific Planning Committee, we're very grateful to them. We have our co-chair, Dr. Bernard Leporn, who's a member of the advisory board, especially for Pallium Project ECHO. And we have Linda Krelestein, who's from the Royal College of Physicians and Surgeons, and Vincent Dagenais-Bourret, I apologize if I've butchered your name, and again, member of the advisory board, and Suzanne O'Brien from Hope and Cope. And this is essentially the conflicts of interest from our planning committee. And members with who have no conflicts of interest, we have David Kenneth Wright, Kim Widger, Devon Phillips, Naomi Goloff, Zelda Freitas, Ellie Fonders, Manny Borod, Bessie Bitsas, Hitesh Banabhai, and Justin Saunders. And just to let you know that this is basically our sponsors. We've got generous sponsorship from various organizations that we're very grateful for. We're able to put this as a result of them. This is essentially the overall Congress objectives that you can find either in the app or the website, and you can look at it in more detail. And then essentially at the end of this activity, this is more the specific objectives. And just before we start, I just want to let you know, if you have the app, it would be really beneficial if you could use the Q&A section within the app. It would make it a lot simpler and easier for us to be able to navigate questions rather than to be able to go back and forth, because we've got some attendees that are online, and it'll just be easier. So if you do have the app, please log on to it and enter your questions there so that we have fewer questions in the hall. But if you don't have the app, no problem. We'll do our best to try and go back and forth between virtual and in-house. So without further ado, our first speaker is... Wrong sheet. Oh, apologies. Our first speaker is Dr. Nathan Goldstein, who's a professor in the Department of Geriatrics and Palliative Medicine at Mount Sinai. And he's got hugely accomplished bio that you can read for yourselves on the app as well as the website. I'm not going to go through it because it would take me an hour just to go through all of his amazing accomplishments. But we're thrilled that he's going to talk to us about end-stage heart failure and palliative care. And so please welcome Dr. Goldstein. Thank you very much.
Great. Thank you oh, good. It's working. Thank you so much. I'm so excited to be here. So normally this is where I kind of go around the room and sort of hear who's in the room and who's from where and et cetera. But let's actually get to the real crux of what we're all thinking this morning. Raise your hand if this is the first in-person meeting you've been to in the last 2.5 years. Wow. Okay. Let me do it the other way. Raise your hand if this is not your first meeting. Okay, so I'd say it looks like 60% first meeting. Now because we're a palliative care group and we can talk about our feelings, let's get to the real question. How many of you are not 100% comfortable being in a room with this many people, like half of us masked, right? Okay, so we're a very confident group, or we haven't quite created the space for trust yet. I'm not sure which it is, but that's a particularly high percentage of confident folks. All of my slides are being previewed now, so basically I'm done. All right, really great being here. Thank you so much. Now, any questions? So let's let this run. It's like having your life flash before your eyes. I'm glad there are no secret questions or answers. Now you've seen all the cartoons, all the jokes are gone. Thanks for the laughter. It helped me a little bit with my personal anxiety. Great. Hey, here we are. Great. Okay, so this is where I come from. This is the view of New York City, that's Central Park. I came in yesterday. This is actually my first time at this conference, so I'm really excited to be here. I also apologize. I did take French in high school. I promise you don't want me to speak to you in French. So those of you coming expecting a talk, this would be a great time to leave because you're going to be really bored for the next half an hour or so. Let's see if I can get this to work. Great. So my only conflict of interest disclosed is that I'm a board member of the American Academy of Hospice and Palliative Medicine. I will just say I'm the immediate past president of the American Academy, so it just gets better. Like, I just want you to know it gets much better next year. Okay. I do a couple quick acknowledgments. I want to thank Dr. Jill Kallman and Sean Pinney, who are my heart failure collaborators, my colleague Dr. Lori Gelfman, many of these slides I heard, and my work has been funded by the National Institutes of Aging and the National Heart, Lung, and Blood Institute in the U.S. The work of palliative care and heart failure focuses on communicator and collaborator domains of the CAN-MEDS framework. I wanted to include this because I actually did email and ask for permission, and I'm so proud of myself for doing that. That's mostly why this slide is here, because I actually did the homework I was supposed to. I'm quite happy of. So after attending my presentation, I hope you'll be able to understand a little bit more about the relationship between prognostication and physiology in advanced heart failure. We'll talk a little bit about using novel techniques in communication and decision-making in patients with advanced heart failure, particularly as we think about cardiac devices. We'll talk a little bit about how to understand and approach decisions about prescribing and particularly around deactivating. And we'll describe a little bit at the end how to manage symptoms in heart failure because there's sort of one sort of secret you need to know and the rest is pretty straightforward. And then I'm going to work really hard to save time for questions at the end. My latent objective is that you'll learn some techniques to improve integration of palliative care into the care of patients with advanced heart failure. I'm very American, so the technique that I'm going to use today is an us versus them mentality, sort of palliative care versus heart failure. We're all working together to improve care of patients with advanced heart failure and their families. So this is kind of my American sarcasm teaching mechanism. So even though I will say palliative care versus heart failure cardiology, that's really to give you a sense of how they think about palliative care versus how we think about palliative care. And but again, it's really all of us working together. Okay, so let's start by talking about the physiology of advanced heart failure and relation to prognosis. And we'll talk a little bit about the relationship of treatments related to both physiology and cardiac function. I'm a geriatrician, I'm a palliative care physician, I'm not a cardiologist. So to the cardiologists in the room, I know there are some, this is my apologizing to you in advance. Okay, so what is palliative care? Palliative care is specialized medical care for people with serious illness. The goal is to improve quality of life for both the patient and the family. It's provided by a team of doctors, nurses, social workers, and other specialists who work with the patient's other doctors to provide an added layer of support. It's appropriate for any age and any stage in a serious illness and can be provided together with curative and disease-directed treatments. So this is not a definition for us, right? This is a definition for our patients and their families. This is an American definition. It has been pilot tested in many different focus groups. That's why it's so doctor-centric, because this actually has been tested word for word with patients and families. And the reason I show this slide is, I know that you all know what palliative care is. The reason I show this slide is because we really have to remember that we have to use different definitions of palliative care talking to patients and families. And particularly when we're talking to our heart failure colleagues or our cardiology colleagues or our primary care colleagues, when we're thinking about integrating the role of palliative care for these patients. This is not new to any of you, right? This is the old two-triangle diagram. We have disease-modifying therapy on the top, palliative care on the bottom, then we have the patient who dies, and bereavement at the end for folks, at least in the American benefit, on hospice. This is the updated diagram that actually shows the two being integrated better over time, where patients have periods of exacerbations and they get better. But I really wanted to break this down. So everyone in the room has probably seen this, a sense of it. It's already known to you, right? But where do we think our heart failure colleagues think palliative care is? Right? So right here, right? So this is very much where our heart failure cardiology colleagues think about where palliative care is. And not some of the work we have to do. And as I'm going to show you in the next several slides, that may also be because of the way that we define ourselves. I'm going to show this a couple of different times. So I'm going to try and walk you through it now so you understand it better, and I can reference it later. So on the blue line, we have the cancer trajectory. So these folks have a sustained period of function, and then they have a rapid decline. And then the heart failure trajectory, patients have exacerbations, and they get better, exacerbations, and eventually they die of one of these exacerbations. Now, I'm going to actually use this as a teaching slide a little bit later. But in general, the issue with the patient in front of you when you're seeing them is you don't know where they are on this curve, right? You don't know if they're here or they're here. I will also tell you that when we think about advanced care planning, I actually have a colleague out of Boston who draws the curve out for her patients and sort of say like, look, I don't know where you are on this trajectory, but at some point you could die of your heart failure. And her response from the patients may surprise you because they've lived this, right? She'll say like, well, you've been hospitalized 3 times in the last year. And they're like, oh yeah, that's true. And your function doesn't always come back up to the point it was. And she'll say, yeah, that's true, right? So when you draw it out in this really direct way for patients, it can be helpful for them. So while this is the heart failure trajectory, and it is true that we don't know where folks are on it, I think the button is stuck. I think that's what the issue is. So let's see. So we and the palliative care view is that every patient in front of you is in this last point, right? So we actually sometimes have a sense of where the patient is in their trajectory, and we may be wrong. This is the ACC, the American College of Cardiology, the American Heart Association pyramid approach to heart failure. We used to use heart failure as class 1, 2, 3, 4. Now it's class A, B, C, D. And the folks at the bottom of the pyramid are high risk for developing heart failure. Then B is asymptomatic. C are the folks who are symptomatic. And D is really the refractory end-stage heart failure folks. A couple of things about this diagram that I think is useful to us. This is very much the concept that most cardiologists and heart failure specialists use to think about their patients. The question is, what happens at the top of the pyramid? Right? So if you're palliative care, you say it's time for end-of-life planning, right? And if you're a heart failure cardiologist, you say it's time for ventricular assist device or transplant, right? And so we actually look at this diagram in 2 very different ways. And again, as I mentioned earlier, in terms of the way that I teach, it's actually not or, it's and. Right? It's probably time to talk about patients, about heart transplant and VAD, and also what happens if something goes wrong. I will also say that we always say that the best place to introduce palliative care is at the time of diagnosis, right? And that makes sense to us. That is based on the cancer trajectory. If you say that to a cardiologist, that actually means here, right? Those are the patients who don't have heart failure, who have hypertension, coronary artery disease, diabetes, right? That's actually not who we want in palliative care. We're probably already overwhelmed in terms of the number of patients that we see, but you'd be so overwhelmed if you really saw everyone right at the start of the illness. So maybe class B, and definitely class C. So even the language that we use to talk about palliative care, which tends to be, comes out of the cancer literature, because that's where most palliative care started, needs to be modified when we think about folks with advanced heart failure. Heart failure is really a global epidemic, so depending on where you are from the world, you can find where you are on this diagram. And you see very high prevalences, and I will tell you that this slide is from a couple years ago. I used to show a slide from like 10 years ago, and these numbers have dramatically increased. Now, the percent isn't great, but remember that's the percent of the total population of each of those countries. Okay, so these are data from a series of ambulatory heart failure populations across the world. And don't worry, I'm going to actually show you the one thing I really want you to notice. But basically, you have the European studies on your left, right? North America in the middle, Asia, the Pacific, and then Africa, the Middle East, and Latin America. And what you'll notice is a couple of things. Let's see if I can get this to work. So, yeah, okay. So this is a disease of older adults. Unless you're in the Middle East, Latin America, then we have it tends to be a younger population. And we're going to talk a lot more. In many of the patients we're seeing, it's not just the heart failure. It's actually multimorbidity in older adults. And I think that's really important to remember, particularly coming to you as a geriatrician as well. This is a fantastic schematic from Hader work, who I've written some with. Hader is at Mass General now. And basically, love this diagram because it includes both the social determinants of health, age, gender, and disparities as we really think about where patients are across the lifespan and what the trajectory looks like. So as you can see, there are issues with ethnic minorities and women, right? So ethnic minorities are more likely to be disabled than whites. Women have longer life expectancy but live more years with disability. And then he actually tracks out throughout all of illness. So then if we just go all the way to the right, we see that it's no longer just about the social determinants of health. It's also about the physiologic conditions of aging, frailty, and when we begin to see more and more hospitalization in ICU, that's how we know that folks are nearing the end of their lives. Current world prevalence is about 63 million cases. That's about 8 per 1,000 inhabitants. And we expect that prevalence to really rapidly increase in the next decade or so. Accounts for 9 million years lost due to disability worldwide. And converted to US dollars, that's $346 billion a year in the care of patients with heart failure. Heart failure accounts for 1.2 million hospitalizations in the US, a 26% increase in heart failure hospitalizations over the last couple of years. There's actually a decreasing incidence of heart failure with reduced ejection fraction. We used to call that systolic dysfunction, and increasing prevalence of heart failure with preserved ejection fraction. And so we're actually seeing that, and those folks have different symptoms and a different prognosis. The total death from heart failure in the U.S. increased from 275,000 in 2019 to 310,000 in 2014. And it is the single largest expense for Medicare, which is the national payer for older adults in the United States. This diagram is heart failure prevalence in older adults. And basically, the most important thing about this is not the categories, but the general increase in slope. Right? So you begin to see that it is really a disease of older adults. So if you can't see at the bottom, that's the 20s to 40s, 40 to 60, 60 to 70, 60 to 80, and 80 plus. Again, this is not just about heart failure, right? It's about the heart failure, the diabetes, the osteoarthritis, the lack of home caregiver, right? And so you begin to see this accumulation of medical conditions and social determinants of health for these older adults. I like to think of it as, what is going to be the top of, in the US, the top line of the death certificate is the immediate cause, right? And so what is the immediate cause? Is it the breast cancer? Is it the heart failure? Is it the fall with subdural hematoma because they were frail and had osteoarthritis, right? So these folks have all of these conditions. The question is, which is the immediate cause of death? And to be honest, does it actually matter, right? What we're going to give them in terms of palliative care is probably very similar. We actually, in America and in Europe, we actually have completely different definitions of what heart failure looks like, and particularly what advanced heart failure looks like. I'm actually not going to read this out to you because you'll see in the next couple of slides, I don't think from a palliative care standpoint of who should we be treating, I don't think the definition matters. These definitions are set up very much to think about advanced therapies, implanted devices, and that's actually what these are for. We have a very different reason for using them, but the point of this slide is actually to more point out the variation across the world and how we even define heart failure. The interesting thing about heart failure is as the disease progresses, so do symptoms. And that's actually why for us in palliative care, it doesn't matter which definition we're using. We're actually trying to figure out when are patients going to begin to have symptoms that we need to be helping them with. So the estimated 1-year survival is 52% for patients with class 3 to 4 heart failure. Now, that of course depends a little bit on what therapies they're getting, but nonetheless, if you take all comers without advanced devices, that tends to be it. That's actually a worse prognosis than cancer. Symptomatic heart failure has a 1-year mortality near 45%. Again, it does depend a little bit on what treatments we're giving folks. If folks are getting VADs or going for other advanced therapies like transplant, that may not be applicable. What is applicable is tremendous symptom burden. Pain, depression, anxiety, shortness of breath, insomnia, fatigue, and anorexia. Originally, none of this made sense to us, right? We never really understood why these folks even have pain. Dyspnea makes sense, but the rest of it kind of doesn't make sense, if you will. And now, as we've learned much, much more around the cellular pathology, the hormonal dysregulation, the inflammatory mediators when folks have uncontrolled heart failure, it is not particularly surprising that they have multiple symptoms. So heart failure is so much more than a disease of the heart. It is really about systemic dysregulation relating to decreased cardiac function. And that is actually why we see all of these symptoms in patients. Okay, I want to bring you back to this, and I'm going to talk about it a little bit more now when we think about communication, and particularly around advanced care planning. So, I can't believe it. Don't laugh, not till I get to it. That was an accident. Hold your laugh till the next slide. I need your positive reinforcement. The blue line, again, is the cancer trajectory, where these folks have preserved function, and then they die relatively quickly once they begin to lose function. Let's talk instead about the heart failure trajectory. By the way, I know the talk after me is end-stage liver disease. They may actually use exactly the same slide because this is really for any end organ function, dysfunction disease, but let's just focus on heart failure. You know what it's like to have conversations with these patients in the hospital. You say to them, you've been in the hospital 1-2 times in the last year. I'm really worried that you may not get better this time, and we should really think about end-of-life planning. And the patient's like, what are you talking about? I've gotten better both times. And then you see them in the grocery store a week later, and they're like, hi, doc, not dead, right? Or you're here and you say, I'm so sorry, your mother came into the hospital, we did everything we could, but this time she just didn't get better and she actually died of heart failure. And they say, what do you mean she died, right? She's been in the hospital 1, 2, 3, 4, 5 times in the last year. Every time she got better, this time she died. You folks did something wrong. And that tends to be because we don't actually explain heart failure in ways that patients and families can understand. I'm going to tell you two very quick stories. One is, this is many years ago, we were called for a patient with advanced heart failure who kept coming into the hospital. Sound familiar, right? Discharge, go home for a week or two, come right back in the hospital, et cetera, right? And they called palliative care to see this patient. And we had a big family meeting, and we sat down like we do in palliative care. Tell me what your understanding is of your father's illness. The patient, although he had capacity, was not interested in speaking to us. He really wanted his children to take care of the conversations. And so they said, look, we get it, right? Dad has advanced heart failure. We know he's going to die of his heart failure. But every time he comes to the hospital, you make him feel better. So we're going to keep bringing him back to the hospital until he doesn't feel better, and then we'll talk to you about hospice and end-of-life care, but not before. It's like, okay, that actually wasn't about disease understanding. It was about the system. Now, that was 10 years ago. Oh, wow. No, that was actually longer. Wow, time flies. I have a patient who just died last week in the hospital who had been admitted once or twice a month for heart failure. It was a very complex case with every possible social determinant of health you can imagine. He had very poor insurance. He had no local caregivers. He did not speak English. He did not read Spanish. And so every intervention we would put in, and he wouldn't allow people into his house to help him. So he kept coming back to the hospital. And people were like, why can't you keep him out of the hospital? And we're like, it's really safe here for him, right? He can't read. He doesn't speak English. He feels bad. He calls 911. They come. He was actually supposed to be on home milrinone. He was discharged in the morning. The nursing service was supposed to be there 2 hours later to bring him his home milrinone. They did not. He does not know how to explain to anyone that he's waiting for his milrinone. So what did he do? He called 911, which is how you activate emergency medical response in the US, and came right back to the hospital. He did eventually die in the hospital, which is terrible from a hospital perspective, exactly what he wanted. So now you can laugh, right? So as this patient's saying, I'm taking better care of my heart, I've started using aspirin as one of my pizza toppings. I appreciate the positive reinforcement, I really do. Thank you, I really need that. But it's actually no longer quite this simple. So this is a diagram. It's old at this point, but I still think it's one of the best from Sarah Goodlin. And basically what you see is what I showed you before, which is these periods of exacerbation. And the other part in heart failure they have is a sudden cardiac death events. But it's really this line I'm going to talk about for a minute, right? This is ventricular assist device or transplant where we completely move folks to a different place on the curve. And that is what I think makes heart failure particularly complicated and particularly interesting. However, it's not just about VAD or transplant. So the work we can do on the heart now is unbelievable. So we have assist devices. We have a total artificial heart. We have transplant. We have work that people are doing actually on the cellular level, the myocardium. We can modulate both the autonomic nervous system. We can remodel the heart, either with surgery or devices. We can reprogram the heart in terms of tailored genetic therapies. And then there are individual repair mechanisms we can do. Now, if you feel like you can't keep up with this, that's the point, right? And what I'm going to say is much of what we do or can do for these patients actually doesn't need us as the palliative care clinicians to be up to date with all the latest advances. When I was a little younger and a little more naive, I used to think that it was the job of the heart failure specialist or cardiologist to do advanced care planning for these patients. And I still remember we used to have, well, I used to go, I don't go anymore, to the 7 a.m. VAD or transplant meeting, which is where the failure cardiologists and the surgeons all got together at 7 a.m. And it was a great place to start this work a long time ago. And I still remember the day where the heart failure cardiologist explained that he was out for the next 2 days to, at that time, learn the latest chemotherapy that they were adapting for immune modulation, reduce rejection in folks who are getting cardiac transplant. At that moment, I was like, you know what? That's probably what you should be doing, right? Let's figure out who else on your team can have that 30-minute, hour-long goal care conversation, because I actually do want you to be out there learning the latest techniques, et cetera. And we'll talk in a few minutes about primary versus specialty level palliative care. There are many mortality calculators for heart failure. Some of them work really well. Some of them don't work so well at the bedside. All of them require inputting a tremendous amount of data into a calculator, whether it's online or on your phone. That's actually why I like this much more. This is work by Lynn Stevenson and colleagues. And basically, it basically shows, so the descending bars are patients with 1, 2, 3, or 4 heart failure admissions. And then at the very bottom, on the far left, is patients without chronic kidney disease, with chronic kidney disease, folks 75 to 85, and then folks greater than 85. But what's most important is, again, the slope. And as you can see, median survival among older adults after the first, second, third, and fourth hospitalization decreases from 2.4, 1.41 to 0.6 years. This is ambulatory heart failure. So it's not particularly surprised that when folks are hospitalized more, they have an increased risk of dying. Although you would be surprised at how often people don't think about that in the hospital. So the patient I just mentioned who died last week, I finally said on rounds, because it was about how do we get him out and how do we keep him out, and I was like, he's dying. Right? I was like, nobody's talking about the fact that he's dying. Now, he doesn't want to talk about he's dying, but we really need to acknowledge that within his plan. I've been working on my slides, honestly, and I pulled this up on the Zoom meeting, and I was like, look, here are the data, right? This patient is dying. And it really helped reshape and reframe a little bit how I thought about his care. I think this is really helpful at the bedside when we're talking to patients, or in the outpatient practice, when we're talking to patients about heart failure and mortality. You know, you've been in the hospital 3 times in the last year. They're not going to argue with that. We know that folks who spend more time in the hospital for their heart failure are really sick. And sometimes they may even be at increased risk of dying. Is that something that you talk about? Is that something that we can talk about, right? We acknowledge that it's scary. We ask for permission, of course, but we can use this kind of prognosis, right? The Seattle heart failure model tells me that in the next 6 months, you have a 53% chance of dying. That's not helpful, right? Patients don't understand that. They don't know what the Seattle heart failure model is, et cetera. But this is like really clear data that you can use regularly with patients that they can understand. So I'm going to talk briefly about technology. We have rapid advancements, that slide you before, in technology that really alter the trajectory of patients with end-stage heart failure. So we have to really rethink the role of these devices in terms of the benefit-burden analysis when patients approach the end of life, ways they can enhance and improve quality of life. And that's what we're really thinking about. You know, you're all probably familiar with the supportive oncology, and people are using much more now the phrase supportive cardiology, which is how do we actually support the patient and family and the goal of the primary care doc, cardiologist, heart failure specialist, right? So how do we actually blend ourselves into that work? These are data from LVAD for destination therapy, right? So you have 2 different groups who get a left ventricular assist device. Those folks who are getting it as bridge to transplant, so we put it in waiting for them to get cardiac transplant. And these are folks who, for whatever reason, won't ever be transplant candidates, or at least right now won't be a transplant candidate. And what it basically shows you, and so let's see if I can get this to work. Perfect. Okay, so this you've seen before, periods of exacerbation, and if we do nothing, we have increased exacerbations, and they die. On this graph here, it's quality of life versus function, but it's a similar graph. And here we have time. And here we have the point of LVAD insertion. Now, before we go over these trajectories, let me just say a couple of things. It was not until I was really working with my advanced heart failure team that I was seeing people with VADs doing well, right? So in the hospital, we are mostly called for people doing incredibly poorly post-VAD. I'm going to show you where that is on the diagram. The thing I like to say to palliative care audiences is you don't really understand these devices until you've seen people doing well with them. By the way, if you're working with the heart failure population, I guarantee you, you're seeing patients with an elevated. In fact, I saw a guy in the airport yesterday, and I felt a little bad for him because he was having to explain what his VAD was to airport security. They're like, can you take this off and put it through the scanner? It's like, no, please don't do that, right? And that was a great example, and he clearly knew how to handle himself, and so he did not need a palliative care intervention to explain it to security. But that was a great example, right? I mean, so his biggest issue is, I can't believe I have to explain what a VAD is. And I knew it was a VAD because I saw the controller and I saw the dry line underneath his shirt. And he was explaining, he was like, no, I can't take it off. I have to wear this vest all the time. And so these patients do really, really well. In palliative care, we do tend to think, oh my gosh, I can't believe they want to give this person a device. It's just we're making money. And the reason that we think that is because we rarely see people doing well. We're only called for this group, right? So these are the people who are getting destination VAD who have a terrible intra-op or post-op event, do very poorly quickly. So most of these folks do well for a long period of time, and then they end up with the terminal decline, what you're used to seeing on the other graphs, or they have a sudden event, either VAD failure, VAD failure is very rare, stroke, significant infection that can't be treated with antibiotics, et cetera. And this actually just shows you what percent fall into each of these categories. So the point is, at this point, you have no idea which trajectory this patient is going to end up on, right? And that's why we argue, hope for the best, plan for the worst. In the United States, Medicare has now mandated that for destination therapy VADs, the team must include a palliative care specialist, which is highlighted there in blue in the bottom. And as you see on the right, palliative care consultation should be a component of the treatment of end-stage heart failure during the evolution period for mechanical circulatory support. So to even get a VAD, destination therapy in the United States, palliative care must be involved. This was not by chance. There was a tremendous amount of work behind the scenes to actually get this into payment guidelines for ventricular assist device therapy. I have to say, I'm used to giving talks on Zoom, and so you sort of forget about these, like on Zoom, it's much easier if you just sort of use your arrows. So this is really a great learning experience, a relearning experience for me. So palliative care utilization of heart failure is poor, right? Less than 10% of patients with heart failure receive palliative care. Less than 12% of hospice admissions were for patients with heart failure. These data are about 10 years old. I will tell you that the data are better, but not great, right? So the numbers are better, but it's still not what you want it to be. 50%, 75%, et cetera. And the evidence base really lags behind that for cancer. There are multiple guidelines that promote palliative care for heart failure. This is actually a comparison document that shows you the various, I think these are all American, AHA. No, the ISHLT is here as well. So some of this is American and some of this is international. And basically what you see, so it's A, B, C, and D recommendations. So palliative care falls in A, B, and C. So very highly recommended within the guidelines to include palliative care in some way for folks with advanced heart failure. So this is, I have a sort of postdoc working with me right now who basically pulled out the most recent European Society of Cardiology and the American Heart Association, ACC, Heart Failure Society of America guidelines, the EU flag on the left, the US flag on the right. I was like, I don't know how to do that. I'm so impressed that you did that. I was like, I'm giving a talk. Could you give me a slide that has like the pretty flags? And then, of course, he was like, oh, I can make it better. I can make them brighter. You know, we can. I was like, no, it's fine. It's totally fine. But I was really like, thank goodness for people with energy and have a lot of technology. So I was really impressed with that. What's interesting here is there are, you see the top three, which is definition, timing, and components of palliative care. There's really a lot of similarity between the two. What's interesting is at the bottom is that the very wordy Americans, of course, have multiple official recommendations for palliative care, where the European Society of Cardiology does not have official guidelines. And that's actually based on how each group grades the evidence and how they look at the evidence. But the point being, these are major guidelines across the world that are guidance and treatment setting that really are incorporating palliative care in various ways now. What I like about this slide, and I'm not going to try and read this slide to you. What I like about this slide is when I used to give a similar talk like this, 15 years ago, I had one study to show you improved evidence that palliative care improves the care of patients with advanced heart failure. This is a paper by Warren Lewin, who used to be at Sinai, now is University of Toronto. I'm having dinner with Warren tonight, and Kristen Schaefer. And basically what they did is they broke it down to inpatient evidence that palliative care improves outcomes for inpatient consultation, which is that top gray bar, outpatient consultation, the next one, outpatient consultation and telephone support, home-based care, and then the use of palliative care for folks with advanced therapies. And so the point of this slide is not to read you every row, but to show you that there's just more and more evidence that shows that palliative care improves outcomes for folks. So I want to switch gears just a little bit now that we've reviewed some about physiology and pathophysiology and the role of devices to really talk about how we work and how we actually incorporate this into the work that we do in terms of communication and decision making. So some of this you know, some of this is a little bit different than, some of this you may know, and some of this is a little bit different for heart failure. So we always start by asking permission to have the conversation. We kind of call that the first ask of ask, tell, ask, right? Ask, is it okay to have the conversation? Ask what they know. Tell them kind of what we know about their heart failure, and then ask them again sort of how that's sitting, and then we can move to goals and ultimately treatments. Is it okay if we talk about your heart disease and what it means for your overall health? So I will tell you, and I'm going to show you some of my own data later about this. When I did teaching for heart failure cardiologists for an intervention that I did a couple of years ago, that first ask was so surprising to them. They had never asked patients if it was okay to talk about their heart failure. What was their question? What was their immediate question to me? Yeah, who said that? So back here. So if you hear, what happens if they say no? Right? So that's why they didn't ask. And I was like, I love it when they say no, right? Because I immediately follow that up with like, tell me more, right? What are you worried about, right? And I explain it like, so now you've opened a whole nother door, right? And it's now a very patient-centered outcome, a very patient-centered conversation, as opposed to like, I need to explain to you about your heart failure and that you're going to die from it, right? Or that you're going to be rehospitalized, or we don't want you to come back to the hospital, right? What are you actually worried about, right? And that's so when they say no, it almost makes the conversation easier for you. So instead of focusing on treatments, we focus on overall outcomes and goals. What's the desired outcome? What's the fate worse than death? Some common goals. And patients are like, what do you mean? I was like, well, some people tell me that what's important is to be able to interact with their family in a meaningful way. Other people tell me they want to be free of pain. And other people say they want to live as long as possible. And they'll say, oh, I would never want to live as long as possible if I can't talk to my family. And I'm like, wow, we just really moved things forward, right? It's in God's hands. I'm waiting for a miracle. It's for God to decide. Okay, we in healthcare may not necessarily agree with that, but it does actually help us begin to focus the conversation from there. Once we've established the goals, we can make treatment decisions. I'm so sorry. That should, of course, say clinicians, not physicians. I will correct that. Clinicians help patients and families by guiding them through treatment options. If the goal is to be able to interact with your family, then perhaps putting you on a ventilator may not get you back to that goal. We don't always agree with the goals, but we may not, but it's easier to determine treatment decisions. So how does this relate and specifically to heart failure? So the conversations are very difficult in heart failure, right? Patients are less likely to believe they'll die from their heart failure. Every time I come into the hospital, you make me better. Why would I die this time, right? and these are quotes from patients. The way I look at it, I don't have an illness. I don't have cancer or anything. I just have heart failure. You don't call it a sickness or an illness. A cardiology colleague of mine in Boston is like, it's heart failure, right? Failure is in the title. But we actually don't explain it to patients' family. We think it's so obvious, but they don't actually understand it. Uncertainty. It's hard for the patient and doctor to say, wait a minute, the patient is changing. There's more exacerbations. It's more difficult to get the person back from the edge. Now, these are actually quotes from patients. Yet patients do want to hear the truth. If there's something life-threatening, don't beat around the bush to tell us. Most of the doctors hold back information. And so the question is, how do we tailor what that particular patient needs in a particular visit, right? We don't have to do it all in one visit, based on what we know about their heart failure. It's also not always straightforward. So Dogbert is saying to Dilbert, here's the first draft against the healthcare directive I wrote for you. And Dilbert is reading it. Tell me if I have a headache. Tell me if I'm itchy. Tell me if I complain too much. And Dilbert says, I might have some edits. And Dogbert says, there's your complaining again, right? Because the process is iterative. Now, I'm going to actually show you in the next slide this ladder diagram because I think it's really helpful. But basically, this is a graphic representation of what Dogbert and Dilbert are saying. So this is, again, work by Lynn Stevenson and artist, I think our first name is artist, O'Donnell. I was actually a social worker who worked with Lynn. And basically, walks you through kind of how the decision-making process works. Now, it feels like a process to you. You've never thought about it this way. This ladder really reinforces that, right? So the earliest, the lowest, the easiest stage is identification of healthcare proxy. Then we go through things like prognosis of heart failure and comorbidities in terms of general health status, and we walk them through the values and goals, talk about preference for care options, acceleration of disease and imminent decisions as the disease worsens, right? Do we want to think about things like ICU, do not intubate, do not resuscitate, and then finally end of life, right? So it's really a process, starting at a lower rung, which may be more straightforward, and then more complex conversations over time. So how do we apply this across multiple settings? So the outpatient setting is always the best place to start these conversations. We can identify the healthcare agent, explore patients' goals and values in the context of illness. Hearing this news, what's most important to you? When you look to the future, what are you hoping for? When folks are hospitalized, we again explore their goals and values. We make treatment recommendations based on goals, and PULSE and MOLST are physician order for life-saving treatment, medical orders for life-saving treatment, which are out of hospital medical orders to be follow the patient across settings. This is particularly important for folks in long care nursing facilities. And then prior to discharge, we continue to explore goals and values and coordinate care and communication goals across settings. So best point we say to have these conversations is in the outpatient setting after a recent hospitalization. It's much less, right? Try not to have them in the ED. Sometimes you do have them in the emergency department. But instead to say, look, you were just hospitalized. I'm so happy you got out of the hospital. I know it's a scary conversation, but would it be okay, asking permission, would it be okay if we talked about what might happen? Things didn't go so well last time, right? So it's much less scary in the outpatient setting than when it's emergent in the inpatient setting. What are the specific techniques that we use? We educate about the heart failure trajectory. As I mentioned, my colleague out of Boston, Vicki Jackson, actually draws out the heart failure curve for her patients. My favorite is hope for the best, plan for the worst. I really do hope you get the transplant, right? I hope we can keep you as well as we possibly can. On the other hand, we do know that you're really sick, and a transplant's a pretty big surgery, right? Patients don't know, oh, it's a big surgery. Trust me, patients know if you're taking out their heart and putting in someone else's, it's big surgery, right? And in fact, you can explore some of their goals and values and concerns around that, right? So I really want you to get better. I really hope that you get better. I'm wondering if you can spend a few very uncomfortable, acknowledging the emotion, minutes talking about what happens if you don't get better from your heart failure. And we can use language like, because I know it's really scary for you, but it's really helpful for your family if they do know what happens if you get really sick or if something were to happen happen in the operating room, which is very, very, very rare. Important for us to remember that as well. It does happen. And it's a fear they already have. And oh, it's such a relief. I don't know how to talk to my family about this, for example. Try not to do this in the emergency room. The best place for advanced care, oh, I said this, is probably the first follow-up visit of the patient's discharge. We have argued in the U.S. that Medicare and the primary care should be paying for what we call an annual heart failure wellness visit, which is not where we talk about the diuretics, which is not where we talk about the kidney function. Instead, that actually pays providers to be able to actually have the conversation. There's actually a way, and we can talk about it if folks are interested in the intricacies of U.S. billing. I know is really what you want to think about how you can do that even if you call it something else. But it's possible to get reimbursed for these visits billing on time. Who has the goal-setting conversation? Is it the primary care physician? Is it the cardiologist? Is it the heart failure specialist? Is it on the stage, relationship, and the setting? Right? If you're at a giant academic medical center and the heart failure cardiologist is who they identify as the main person, here's your answer. If you are seeing a patient in a rural setting who doesn't have a cardiologist they can see very easily, it becomes a primary care clinician. Is it a physician? Is it a nurse practitioner, a physician assistant, social worker? We're doing a lot with community health workers, which are lay patient navigators with special training who tend to come from the communities where patients are, who can do really amazing advanced care. They can't do it all, but they can get much further in the process than you might think because it's much less scary when they talk to the patient. Is it the role of specialty level palliative care, or is it the work that we should be doing to train others in this, right? That the primary palliative care. And this is work by Diego Cavalertos, who recently moved to Atlanta in the U.S., actually walks out what is the role of heart failure management, what is the role of primary palliative care, that is, what kind of palliative care do we expect a heart failure cardiologist, primary care team, whoever's doing the failure management, do, and what's the role of specialty level palliative care, right? And some of this is about patient assessment, choosing therapy, managing the exacerbation, right? You don't want me managing your heart failure exacerbation, but also predicting and communicating prognosis, because they're going to believe prognosis information much better from the cardiologist, the primary care doc, whoever they trust, than me, who just meets them for the first time. We control pain and other symptoms, and we also expect some work around control and pain and other symptoms, assisting with medical decision-making, advanced care planning, coordination care across the patient's team, and then we bring in specialist level palliative care on top of that. The other thing that is really interesting is, can the patient take the lead in these conversations? This is a website by my colleague Rebecca Store out at UCSF in California called prepareforyourcare.org. I'll say that again, prepareforyourcare.org. It is free. It is English and Spanish. She is having it translated into Chinese. It's asynchronous, so you can come and go as you please, and basically it takes patients through a whole series of questions. My favorite is either this conversation is too scary, I don't even have it. So there's a whole path that goes for them. And there's also a path that, like, I don't have anyone to help me to make decisions with or for me. What do I do? And it's a whole series of videos that sort of take patients through the scenarios. It's really, really great. I highly recommend it. Again, prepareforyourcare.org. It is free, and it's aimed at folks with lower health literacy, so it's pretty straightforward. At the very end, it spits out not an advance directive, not a legal document, but instead it will print a customized outline. Patients take to their healthcare provider and say, I went on this website, this is what I want to talk about during this visit, right? And sort of walks through the decisions they've made and the questions they have, and becomes not only a communication tool for them, but also amongst them and their family, but also to be used with their providers. So let's quickly talk about deactivating and deprescribing, and also kind of some of the prescribing that we do for these folks. So just remember that any patient with capacity or with a proxy or surrogate, depending on the local laws, can withhold or withdraw any treatment or device. Withholding or withdrawing are legally and ethically equivalent, in most regular encountered scenarios. We can talk if folks want about those specific scenarios at the end that people always want to talk about. At the bedside, however, withholding and withdrawing may feel different to the clinician because one is passive, I'm not going to put you on this ventilator, versus active, we're going to take you off this ventilator. Legally and ethically, they're the same. It feels different at the bedside. As a device implanted does not mean it holds special ethical significance, even in the case of the pacemaker-dependent patient or the VAD or ECMO, which is extracorporeal medical oxygenation, right? I think is what it stands for. Membrane, thank you. Oxygenation, thank you. There is an issue with deactivation versus removal, right? We deactivate ICDs, we don't remove them. We do obviously remove ventilators, so it depends a little bit on the device that we're doing. This is a study that we did several years ago, a 6-hospital, 5-year randomized controlled trial of a clinician-centered counseling and support intervention to improve communication between heart failure clinicians and patients with ICDs. We randomized at the hospital level. The intervention was focused on the heart failure clinicians, and the patient was the unit of analysis. Our work was funded by the National Heart, Lung, and Blood Institute in the U.S. What we did was an educational intervention, which we basically, everything I just told you, we sat down with heart failure cardiologists and taught them. Ask, tell, ask, goal setting, tailored treatments, showed them the video of an ideal conversation. We made them role play. That was fun. And we had an automatic reminder system that reminded them they should talk to patients about their heart failure. And we used their control. So basically, it was just to teach them how to talk to patients. We enrolled more than 500 patients. They're similar in terms of age, gender, race, and cardiac history. They did tend to be, well, they actually were a younger population than what we may see generally. And these are our main results. So on the first 2 columns are the entire sample. The middle column, the middle 2 columns are patients who are not candidates for advanced therapies. And the column on the right are the deceased patients. And on the left, you always have intervention and control. So in the entire sample, there was no difference in terms of device discussion or deactivation. However, in the folks who were not candidates for advanced therapies, there was a significant increase in conversations, which are these 2 bars together, as compared to the controls. And what these 2 bars are is actually these 2 bars, right? So more patients who were not candidates for advanced therapies had discussions about device deactivation compared to control patients, but there was no difference in actual device deactivation. And that is okay with me, right? Because what I want to do is make sure patients know that they can be shocked by our ICD at the end of life, and that they have the option to turn it off. And it shows that our intervention actually improved. We actually taught the heart failure clinicians how to have those conversations. What's interesting is that the numbers are very similar in the deceased sample, which is why it's not statistically significant. What this tells me is that we taught cardiologists a new skill that they chose to turn on or off depending on what therapies were available to the patient. That was a huge success that I had not expected. What about other therapies? Again, align benefits and burdens to goals. Remember, the benefits are often different than what we think they might be. Resynchronization devices make patients feel better. VADs make patients feel better and live longer. When you ask a patient, how do you feel about your VAD? They say, you know, I can walk across the room now. I didn't used to be able to do that. Right? So they really make people feel better. Medication deprescribing, is there a benefit now versus later? The most important thing I can say about medications in general in this population is, remember, the best palliative treatment for heart failure is treatment of the heart failure. So the best treatment for heart failure is shortness of breath is not necessarily opioids first line. It's more Lasix, right? Or reevaluating Lasix, or trying to figure out if they're in the middle of an exacerbation that we can reverse. But, you know, so the diuretic, you probably really want to keep them on that. If you think they're really at the end of life, it's unclear if the cholesterol-lowering medication actually has a benefit. Why is a patient on anticoagulation? Is it for the multi-year risk of stroke, or is it because they have a VAD, right? So I don't have a lot of single pearls because each patient is different. I can't tell you like, you should always stop these medicines. You should always keep people on these medicines because it is so patient specific. But remember, our guiding principle is around the treatment of heart failure in general. The list of symptoms in heart failure is lengthy. I went over all these before, right? So I went over all of these, and again, the best treatment for these is management of the underlying heart failure. That's actually the most important thing I want you to take home, is not which medication is right, and I am going to go over the morphine dose in a second because people always ask about that, but to remember that it's actually things at the underlying treating of the heart failure that makes these patients feel better. So in cancer, we can see very large doses of opioids, right? I give my morphine 30 milligrams by mouth 3 times a day. I write that in outpatient all the time. I don't bat an eye, right? Large doses of hydromorphone, fentanyl. In heart failure, morphine 5 milligrams by mouth every 1 hour is needed for pain may really help them. The dose for dyspnea is very different than the dose for pain. Fears about low-dose opioids in this population tend to be unfounded. And specifically, the fear that you have to help people understand is if I give this patient 5 milligrams of oral morphine, they're not going to stop breathing, even in their compromised underlying cardiac status. So now what? So how do we actually improve reaching out to folks, right? So the first is to acknowledge the complexity I've been going over for the last hour, hope for the best, plan for the worst. Cardiologists, it's interesting. When you speak to oncologists in general, they say, like, I need help with the pain. I can do goals of care, but I need help with the pain. When you ask heart failure clinicians, they're like, no, I actually don't need you to tell me how to manage their symptoms. I'm really good at managing heart failure. I want you to help the patient understand where they are on the illness. So what is it that the referring clinician wants us to help with? It's really important to remember that depending on the patient, cure, transplant, or stabilization, LVAD, may be right around the corner. Cure and stabilization are in quotation marks because if you put this in front of a group of heart failure cardiologists or cardiologists in general, or maybe the Thyroid Society down the hall, I'm not sure, they will basically tell you that in some ways you're swapping out one problem for another, right? So it's not really cure, but from the patient standpoint, transplant, they feel like transplant is cure. So what is the goal of our work? The goal is not to force acceptance the patient is at the end of life. We're not forcing on the patient, not on the family or the referring clinicians. Instead, to help patients and families understand the complex trajectory, clarify goals, and review over time, right? Assist with conversations and not take them over. Support the plan of the primary cardiologist, primary care doc, whoever is seeing the patient, and helping improve, maintain quality of life until either advanced therapy or end of the patient's life. The role of device therapies can make these conversations more complicated, and of course, we assure symptom control at all times. This is our heart team. This is our supportive cardiology team. It includes, of course, the bottom left with the heart is the cardiology team. The folks standing on the stairs there is the palliative care team. This woman right here, Karen Heinz, is our nurse practitioner. She rounds on the inpatient cardiology service with the heart failure docs. She's the one who now has to go to the 7 a.m. VAD meeting. She knew it when she took the job. Let me just be clear. And she goes to outpatient rapid follow-up clinic. So she is the continuity of care. When these folks come in 2 days after they're being discharged for their heart failure, she actually sees them. It was actually Warren Lewin, who now is at University of Toronto, who created this model. And after Warren left, we hired a nurse practitioner to do it. These are some of our own data, and we're still working on it, so the numbers weren't quite ready for you today. But as compared to patients for whom regular palliative care consults were called for, when we have an embedded palliative care team, the patients that the embedded team saw were more likely to be younger, have higher functional status, have capacity for medical decision making, have lower mortality, more likely to be discharged home. We get to see folks much earlier in the course when we can actually do much more work with them from a palliative care standpoint. So I get this question, who's the right heart failure patient to refer to special level palliative care? And these are just some general guidelines, right? Uncontrolled or refractory symptoms, patient likely to die on this admission, complex home or social situation for discharge, 2 or more heart failure hospitalizations in the last year. I showed you that based on mortality data. Multiple transfers between long-term care and the hospital. The patient or the family don't seem to get it. Get it is in quotation marks here because, of course, sometimes they don't get it because we don't explain it well. And sometimes they totally get it. We just haven't built a system around them that helps them achieve their goals. I don't know. We talk about end of life. I don't know. People hear palliative care. I don't know. So the data are very clear that actually patients and families in general don't even know what palliative care is. So this is language from the Center to Advance Palliative Care. It's a very simple way to introduce supportive cardiology. We're going to ask a team to come by to see if there's anything they can do to help you live as best as you can with your heart failure. That team is called palliative care. Right? Nothing about end of life, nothing about dying, nothing about serious illness. We're going to help you live the best quality of life you can. The team that specializes in that is palliative care. It's pretty straightforward, and then patients will begin to figure out how we can help them if you introduce it in a way that isn't scary to them. So patients with heart failure have significant palliative care needs. Heart failure treatments change prognosis, trajectory, and the nature of the discussion as it relates to devices. And palliative care is tailored to different populations of patients with heart failure. Palliative care tailored to different populations of patients with advanced heart failure can improve the quality of life for patients and their caregivers. Now, I've been to a lot of conferences, and I know that I'm the first thing, right? So you're really not going to remember all of this. Adult learning theory tells us very clearly that the best way to change your personal behavior is to commit to one thing that you're going to do. If I was particularly on the ball, I would have brought a bunch of postcards, right? That's actually the way to do it, is to have you mail yourself a postcard that shows up in the mail a month later, but I cannot even imagine how I would deal with international postage, right? So write yourself an email right now or right when I'm done. Most of you are on your phones anyway, which is totally fine. Write yourself an email about what's the one thing you're going to take from this talk. Are you going to draw out the curve for patients? Are you going to start using hope for the best, plan for the worst? Are you going to teach this to your heart failure colleagues? Can you do this with one patient? Well, probably not this week, but next week, right? And this is my favorite one. What will you do differently with your heart failure colleagues after hearing this talk to better improve palliative care for them? I'm going to leave this slide up because it also has my email address on it. But thanks so much for your attention very early in the morning. I'm happy to take some questions now.
Thank you so much, Dr. Goldstein. We've got quite a few questions actually on the app. So for those of you who don't know the app and you really, really want to come up and ask your question in person, that's okay. But I'm going to start off with the app just to get us going. Dr. Goldstein, you had mentioned a little bit about pain and inflammatory process that happens in end-stage heart failure, but could you please explain a bit more about why patients with heart failure have pain and if there's a specific type of pain or an area that they get?
Sure. I can explain the best I can. One of the things about palliative care, and I'm a health services researcher, right? So I'm blaming myself in this, is we do very, very little basic science research, particularly in the US. I think that may not be the case everywhere. So what I don't have for you is here's the randomized controlled trial of, this therapy and how it reduces cytokines, for example, inflammatory mediators that to actually demonstrate the improvement of morphine, et cetera. You can't use non-steroidal anti-inflammatories in these patients, which is how we would normally treat pain that we think is inflammatory in nature, because, of course, of the risk of worsening their underlying kidney disease. So here's what we think, right? We normally think about heart failure as do you have chest pain, right? As some sort of acute coronary syndrome, some sort of unstable angina. What we see much more commonly is in these people is not, yes, it's like an elephant sitting on my chest, going down my left arm, right? They rarely have the symptoms of acute MI that we were taught to ask for. Instead, what they describe is almost more like an osteoarthritis pain. I have a general achiness in my whole body. Sometimes it's worse in the morning, sometimes it's not, etc. And that's actually what we see, and that's because it's not, the autonomic nervous system trying to say this person's having a heart attack, take them to the cath lab. Instead, it is about dysregulation of hormones and cytokines, mostly related to both sort of right? Because now know that the heart actually secretes a lot of different hormones, as well as the relationship to the underlying kidney disease. It's actually very similar to what you see chronic, diffuse, all over body pain in folks on dialysis. So, and in general, Tylenol works really, really well for these folks, and sometimes physiotherapy. But again, you want to stay away from ibuprofen and other NSAIDs in this population.
Thank you.
Thank you. We have quite a few questions about advanced care planning, so we'll pick a couple. Should we not be working together as palliative care and heart specialists to have these advanced care planning discussions?
Yes, absolutely. You should be working with the heart failure cardiologist or the cardiologist. Here is what I like to do. Have them either on the phone or on Zoom or in the room. And in my family meeting, we ask permission. We ask what the patient knows. And then I say, I'm wondering if heart failure cardiologists can actually talk a little bit more about your heart failure and the options for it, right? And then when they tell, right, tell them what we understand about their illness, I say to the patient or the family, do you have other questions for heart failure cardiologist? Because I know she is really busy and she needs to go see other patients, but I really wanted you to hear it from her. But she can't stay as long as we can. So I want to get your questions answered, and then we can talk some more about options, and then I can circle back to the heart failure cardiologist or the cardiologist, right? Because they do not want to be in a 90-minute family meeting. They do want to be involved in the patient's care. So yes, we do it together, but we give them exit door. Sometimes they'll say, no, I want to stay, right? Because of their relationship. And sometimes they'll say, thanks, I have 30 people I got to go see in the hospital, right? So we do have them in the meeting. We give them an early exit. So the meeting is only 15 or 20 minutes for them, whereas for us, it may be an hour.
Thank you. I want to ask you about Dr. Sean Morrison's work in advanced care planning, where he's not so impressed with advanced care planning, and I just wondered, Dr. Goldstein, do you have an opinion about that?
Oh, do I have an opinion about Dr. Morrison's work? So back to the disclosure slide, just to make sure everyone knows, Dr. Morrison is my boss, right? So let's just keep that in mind. However, he's also a mentor of mine, so we've had some pretty intense conversations around this. It is really about what definition that you're talking about, right? So Sean does not argue that identifying a healthcare agent is important. What Sean's argument is that the evidence that we have a conversation now about what may happen 3 years from now doesn't bear out, right? And so it depends on if you think about advanced care planning as preparation for in-the-moment decision-making, and that's what my colleague Rebecca Dore says, really all these conversations are preparation for in-the-minute decision-making. Or if you're really looking at what the patient said on the document and what the outcome is, right? So what Sean has shown is there's not a lot of correlation between what they write on the document 2 years in advance and what they get at the end of life. And that is actually not new. Terry Freed out of Yale showed a long time ago that as patient's illness worsens, so they adapt, right? I would never want to be in a wheelchair. Oh, I'm in a wheelchair now, it's not so bad, right? And that, I think, much better lines up with Sean's work around this, and his argument is that goals and decisions change over time. And so I think, in my opinion, it's actually somewhere in the middle. Sean's other argument, as someone who argues a lot around research money, is also one about where we should be spending our limited pool of research dollars. Dr. Morrison is at the National Palliative Care Research meeting right now in San Diego. His email is sean.morrison@mssm.edu. Please feel free to email him with those questions. I'll tell him, questions coming from Canada. He'll love that.
Yeah, lovely.
Yeah. Again, sean.morrison@mssm.edu.
Go ahead, Bruno.
Good morning. I'm Bruno Gagnon from Palliative Care in Quebec, and I've been exposed to some heart failure patients. Thank you for your presentation. It was very clear. Here in Quebec and probably elsewhere in Canada, we have heart failure clinic or rehab clinic. Do you have those, and how do you get involved if you have some?
Yes. So how we got involved was years of trying to work to get in the door. So there are a couple different models in the U.S. What we have is the nurse practitioner I showed you who goes to the rapid follow-up clinic. So she practices she's an embedded practice. She goes to another practice and sees patients there next door to the cardiologist. That's the model that works best for us. There are other models where it's a freestanding supportive cardiology practice or where they are embedded in the regular heart failure practice. This clinic that she goes to is just folks that have been hospitalized recently. There are other folks who do supportive cardiology where they are in the heart failure practice all the time. What works is and there's a whole series of models across the U.S., and that's based on issues around room availability and reimbursement. Does that answer your question at all?
Yeah, we have program of rehab with physiotherapy, ergotherapy, nutritionists that will do a program for 8 weeks, 12 weeks. Do we have similar program? Because it would be an interesting place to insert the palliative care approach.
We don't. The best we have is cardiac rehab, which would actually be a great place to do it, but I don't know of any models that all of our palliative care models are interdisciplinary, but it's normally physician, social worker, nurse. It's pretty rare to have physiotherapy and others integrated. It's a great next study. Thank you for that. Yeah, thank you.
Thanks, Bruno. Dr. Goldstein, I know you mentioned that palliative treatment, the best palliative treatment of heart failure is the treatment of heart failure, but are there ways that palliative care can improve heart failure outcomes?
So most of the work around palliative care outcomes is, again, not around treatment. Unfortunately, we can't improve systolic function, right? We can't improve the diastolic dysfunction. The outcomes are very much around utilization, decreasing costs, decreasing visits to the emergency room, decreasing ICU stays. There are some very clear data that palliative care earlier on increases hospice, which is the U.S. program for life care. It's a comprehensive payment model, increases both the use of hospice, but most importantly, length of stay on hospice. Some really interesting data, retrospective, that shows folks on hospice, which is a comprehensive program of end-of-life care, actually have longer hospice stays, live longer on hospice than folks not on hospice. That isn't because hospice cures heart failure. That's actually because in those folks, hospice becomes a comprehensive disease management model. What I mean by that, you have a nurse. So in the U.S., you have to have a skilled nursing need to have a nurse come to your house. On hospice, everyone gets a nurse that comes to their house. So you have a nurse who comes to your house every week and is like, let's check your weight. Oh, your weight is up a little bit. Let's increase your basic dose for 3 days, right? We think that's actually why some of those models of end-of-life care actually let people live longer, because they incorporate either directly or because of the palliative treatment that folks actually live longer on hospice.
Thanks. We have a question about the WISDOM trial. Did heart failure clinicians display much enthusiasm in participating in the WISDOM trial?
They did. Every clinician that we tried to enroll actually enrolled. We had 100% enrollment of our clinicians. Heart failure clinicians know this is important. They know that they don't have the time to do it. I think we're in a different place than we were 5 and certainly 10 years ago, right? There's so much evidence, right? So, and now it used to be like, we think this is important. Now I'm like, here's a whole stack of documents from your societies telling you that you should be doing this. The hurdles we face now are much more around reimbursement and arguing for resources from hospital and school and insurance. We are seeing there are many new insurance programs. I know you Canadians totally want to hear all about the crazy American healthcare reimbursement system, sort of shared savings model, so partnering with insurers, because we know this improves outcomes by decreasing costs. And that's actually some of the most exciting stuff we're seeing right now in the United States, is we call it risk contracting. It's risk sharing, where to ensure any money saved from that patient is actually divided between the people doing the work and the insurance company. And so we're actually seeing of new payment models around this, which is really important to us in the US.
Thank you. Are there standardized and easy to use benefit burden decision making tools for ECMO or other newer devices with key outcomes and complication risks? It's a long question.
So there are several for folks on vents. There are multiple things you can do to determine mortality for folks on ventilators. I will say, not that I'm aware of, that may be more in the cardiology literature than I tend to delve into. So I don't think there are any particular risk models for folks on some of those kind of advanced therapies. I could be wrong, so anyone in the room, please correct me.
I want to switch gears a little bit and ask a question about education, because we've talked about capacity building for primary or supportive cardiology, as you worded it, which was lovely. Is palliative care a mandatory part of medical curriculum and cardiology in the US? And do you think this would change the future role and need of our specialty?
Yes and no. All medical students are required to have some amount of palliative care education. The key phrase there is some amount, right? So at Mount Sinai, every third-year medical student spends 2 weeks on our inpatient palliative care service, right? But sometimes it's a single lecture somewhere buried in their curriculum, so it depends on the medical school. What we're seeing now is actually demand for it from palliative care cardiology fellows, right? So they're going to their program leadership and saying, like, why aren't we getting more lectures on palliative care? Why aren't we talking more about communication training? So the most robust changes right now are coming from the learners actually asking for it, demanding it, being more likely to go to training programs that have it well integrated or have strong palliative care services. So there are some mandates, but what we're seeing now is sort of a generational change, and where the impetus for the education is no longer from above, but from the folks actually experiencing the training.
So this is a question that's in the same vein as Bruno's question, but how do you, for those of us who want to start off these clinics, how do you identify the right stakeholders in organ failure clinics?
How did I meet Sean Penny? I don't remember. It's been so long. I would start with start with a series of discovery conversations, right? Just sitting down and talking to the stakeholders, the chief of cardiology, the more junior cardiologist who just came out of training, the cardiologist that calls you all the time when they're on service for their heart failure patients. So find the stakeholders that you think are going to be particularly interested in this. Find someone in cardiology in hospital, medical center leadership, and say, hey, I got this great thing. It will improve quality of care. It will reduce costs and will improve throughput in the cardiology clinic, right? It's a win-win-win. So that's the argument, right? You need palliative care. You should have palliative care. Right? None of that. Hey, I have this great thing. It's going to help you, the clinician. It's going to help the patients. It's going to make the hospital happy. Can we talk about ways to integrate it? And so really strike for that win. And again, turns out every negotiation is really just a family meeting. So you say to that colleague, hey, what do you know about palliative care and what are your thoughts about it, right? And so we don't start with, we're not end of life care. We start with, what do you know about palliative care and how can we help you with your patients with heart failure? So find those folks. You got to have a lot of conversations over coffee with them, and start with these very open-ended questions to figure out where you're going to start.
I'm just going to take one more question online first, Kirsten, because it's related to what we were just chatting about. So while we wait for cardiologists to respond to our ask about whether we can integrate into their clinics, what can we do to support patients living with heart failure?
I think if you haven't found that champion, then we have to empower patients to have the conversations. Look, if you have questions about your heart failure, you should really ask your cardiologist, right? But can we write out 3 questions you really want answered, and then I want you to take this piece of paper into the cardiologist. I love to sort of send an email and say, hey, I spoke to Ms. Jones today. I want to let you know that she came up with these 3 questions spontaneously. I mean, maybe I prompted a little, but I'm not going to say that, right? Prepare for Your Care is a great website to do that. Again, and patients will print out this document and they can sort of put it on the table in the exam room and say, I went on this website and I want to talk to you about these things. And it's really, this is so much more about patient empowerment, I think, than it is about palliative care per se, but the same techniques you would use to either kind of pave the way or empower them or both. Yeah.
Kirsten Wetland, please go ahead.
Hi, lovely talk. Just a point about getting into patient care in our heart failure clinic first before I ask a question.
Yeah.
We found it easier to integrate when we became part of some type of thing heart failure was doing. So the general heart failure clinics were very hard to integrate with because it was patient-to-patient case, where we now see all the VAD patients, all the patients being assessed for VAD, all the patients being assessed for transplant. It's given us a mighty presence in that group, but I must say that individual heart failure patient that's failing within the heart failure clinics, they're still not getting referred, but we're seeing now hundreds over the course of the year.
Yeah.
One other thing, I actually argue that transplant is a palliative intervention, and I constantly tell my transplant specialists that. The last is a question. We recently completed a study where we asked cardiologists across Canada about palliative care, access to palliative care services, and also their attitude towards palliative care. And much is not surprising and also shared in the US. But one question we did ask is how cardiologists felt about palliative care's knowledge of heart failure management. And over a third to maybe 40% of cardiologists felt that palliative care didn't have adequate knowledge to treat their patients. So how do we change that?
Yeah. So thank you for those comments. Congratulations on the work that you mentioned you've done. I mean, I 100% actually agree with them. We don't, right? That's actually why when I give this talk, I set up the us versus them because we do assume, like I showed you earlier, we assume every patient in front of us is at the end of life. We assume that there is no use in giving them the VAD. We assume that they're never going to get the transplant, right? And so, and many folks have written about this, which is what is the role of palliative care and how do we improve our knowledge? And so, I still remember the time when I was doing a VAD study and the cardiologist was like, so are you just talking VADs? Do you also want to include folks with total artificial hearts? And I was like, oh, we're doing that now? Right? And so I was like, sure, we should totally include folks with total artificial hearts. And then this was not someone that I knew. And so then I emailed a cardiology colleague and I was like, yeah, I don't know what this is, right? And she gave me a whole lovely email back explaining what it was and how it was sort of a little bit of a misnomer and, those kinds of things. And so I think we need to read, right? We need to go to the American Heart Association meetings. We need to go, they're huge. We need to now listen to a couple online Zoom lectures. Our heart failure docs come every other year to our geriatrics and palliative care group and give a one-on-one heart failure 101. We're like, this is the current state of the art for heart failure. So invite them in as grand round speakers, not because they like or don't like palliative care, but because look, we want to be better integrated. We want you to teach us about heart failure. So make it easy for people to learn. When I go to that sort of intro to sort of heart failure care, I know that I am not going to be dosing these medicines, but I just want to know what new therapies are out there. So those are the kinds of ways that we can educate ourselves. But first acknowledge that you have the knowledge deficit and then figure out ways to improve it. And I think inviting cardiologists to come talk to us opens the door in a whole different way, right? So you invite them to come talk, and then at the end, you raise your hand and say, hey, how do we better integrate into your services? So we've learned from them, and then also, because they're not going to say in front of a group of 30 people, you can't, we don't want you, right? So it can be a technique to do a couple of different things.
Thank you so much. And Kirsten, I think the other aspect of that is making sure that we have as many of our faculty going through and trained appropriately, like our 2-year residency program. That's the whole point of doing that, right? So I think things will change, definitely.
And they have, yeah.
we've run out of time, so I just want to thank you, Dr. Goldstein, on behalf
Thank
of
you.
all of us.
Right.
For your brilliant talk, as well as my brilliant co-moderator. And thank you on behalf of the Canadian Society of Palliative Physicians and the McGill Congress.
Great. This was great fun. Thank you all so much.
So we have a 30-minute break. Please do feel free to stretch your legs, take a bathroom break, get a drink. But we're going to start again 10:30 sharp. So please be back here before then.